It's a very nice forum for students. So, Dr. Pooja, you are there?
Yes, sir. Am I audible, sir?
Yeah, you are audible.
Good evening, everyone.
Okay. Am I audible to everybody?
Yes, sir.
Thank you. So, I'll be studying questions based on the specimen that will be displayed on the screen. So, Dr. Pooja,
Yes, sir.
whether specimen is visible to you?
Yes, sir. It's visible, sir.
Okay. Can you identify the specimen and the pathology in it?
Yes, sir. This is a coronal section of the brain showing a ulcerative lesion in the left hemisphere with areas of necrosis and hemorrhage. The lesion is also crossing the midline, sir. So, the most likely diagnosis is glioblastoma, sir.
Okay, very good. So, can you tell what are the histological findings in case of GBM?
Yes, sir. In GBM, the most common histological features are necrosis, cellular atypia, and high mitotic activity, and endothelial or microvascular proliferation, sir.
What marker study you like to do for this patient of
Sir,
type of tumor?
sir, the markers usually we look for our IDH and MGMT methylation status, sir.
How it is you can correlate with the treatment of the patient?
Sorry, sir.
How you can correlate this marker
Yes, sir.
IDH and MGMT with the treatment of the patient?
Yes, sir. MGMT, actually, MGMT promoter methylation is associated with a better prognosis because it responds better to temozolomide chemotherapy, sir. And also, IDH mutated patients, they respond well to temozolomide, sir, comparing to IDH wild type patients.
Okay. Can you outline the treatment options for this patient?
For this patient, the ideal treatment should be maximal surgical resection followed by adjuvant RT with concurrent temozolomide, followed by adjuvant temozolomide, sir, for 12 cycles.
Can you tell the dose of temozolomide that we gave with concurrent setting and on adjuvant setting?
Yes, sir. In concurrent setting, the dose is 75 milligram per meter square, taken daily just before RT, and the adjuvant temozolomide dose is 150 to 200 milligram per meter square, sir.
How long you will give?
Sir, for 12 cycles, sir. 6 to 12 cycles, sir.
How is the prognosis for this type of patients?
Sir, in IDH mutated patients, if we go for a maximal surgical resection followed by adjuvant treatment, the overall survival is 14 months, sir. If with no treatment, the survival is usually 4 months, sir.
Okay, nice. Come to the next slide. Is it visible?
Yes, sir, it's visible, sir.
Identify it.
Yes, sir. This is a gross specimen showing mandible because I can see teeth attached to it. So this is a hemimandibulectomy specimen, sir.
Okay. List two imaging modalities that is commonly used for this type of patient in pre-operative setting, which will guide to treatment.
Yes, sir. The imaging that we commonly advise is contrast enhanced CT to look for to know about the extent of the disease and to look for bone erosion, sir. And other imaging is MRI to look for that is also know about the extent of the disease to know about perineural invasion, sir.
Okay, this is basically an oral cavity tumor.
Yes, sir.
So, what are the other subsites in oral cavity? Can you tell?
Sir, other subsites starting from lips, buccal mucosa, tongue, RMT, sir.
Tongue, okay,
Floor of mouth, sir.
okay. Besides oral cavity, there is another site there that is called oropharyngeal.
Yes, sir.
And other sites are also there, pharynx, hypopharynx. So there is one virus that affects which part of this and it causes cancer. Can you tell?
Yes, sir. Oropharynx customers are usually associated with HPV, sir. HPV infection, sir.
Clinically, can you tell that it can be SPV positive or it can be SPV negative?
Sir, in HPV positive cases, there will be usually high nodal burden, sir.
Good, very good. How will treat such type of patients in adjuvant setting?
Sir, adjuvant treatment will be decided based on the post-op HPV, sir.
Yes.
Sir, post-op HPV, if it is a P, T3, T4 disease, closed margins, LVSA or PNA positive, and node positive patients will go for adjuvant RT, sir.
Okay. What is the treatment option for T1, T2 tumor?
T1, T2 tumor, if it is there is no nodal involvement, we can go for brachy, sir. If the lesion is up to 2 centimeter and it is not close to any bony structure, we can go for we can plan for brachytherapy, sir. Otherwise, we can go for upfront surgery, and based on the post-op HP, we can decide the adjuvant treatment, sir.
Okay, you have mentioned about brachytherapy. So can you tell the indications of brachytherapy or in which patients you can take for brachytherapy?
Yes, sir. If it is a very early disease, size up to 2 centimeter, and clinically node negative, and also we should get the ultrasound neck done, sir, to look for any nodes. If it is node negative and very localized and small size, we can go for brachy, sir.
What is that size?
Size up to 2 centimeters, sir.
It should be less than 2 centimeter.
Yes, sir.
It should not be near any bony lesion. It
Yes, sir.
should be approachable. Then only we can take it for brachytherapy, but not this type of patients.
Yes, sir.
Vocal mucosa, oral tongue, this type of patients we can take for brachytherapy in early cases. In that scenario, suppose you have taken for brachytherapy, what other things you will do for the patient treatment purpose?
Dental evolution, sir, just before treatment.
Okay, dental evaluation, nutritional evaluation, these things are.
Huh.
Then what treatment you will give? You have chosen brachytherapy. Any other treatment patient requires?
Sir, sir, with concurrent chemo, sir.
No. You have to go for nodal dissection also.
Okay, sir.
Nodal dissections.
Yes, sir.
Okay.
Yes, sir.
You have to give brachytherapy to the site that you have chosen. And also, if required, you have to go for radiation of 45 by 25.
Yes, sir.
Can you see the next slide?
Yes, sir.
What is the specimen about?
Sir, this is a gross specimen of the lungs, sir, because we can see the bronchoalveolar markings, sir. So this is a specimen of lungs, sir.
Bronchoalveolar tree.
Yes, sir.
And there is pigmentation, black pigmentation.
Yes, sir.
So this is most likely, or it is lung. So what is the pathology it is showing displaying?
Sir, we can see a centrally located lesion which is white and friable, sir. So based on the gross appearance and location, it is most likely.
Gray. It is grayish, irregular.
Yes, sir.
Liable you cannot tell from the specimen.
Yes, sir. Yes, sir.
Okay. Centrally located. So what
Yes.
is the likely histology it can be?
Sir, it could be squamous cell carcinoma, sir, because squamous cell carcinomas are usually centrally located, sir.
Okay. And what is peripheral located?
Adenocarcinomas are usually peripherally located, sir.
What are the other types of histology you can find in lung cancer?
Sir, the other types of histology are small cell carcinoma, large cell carcinoma, mesenchymal tumors, sir.
What are the risk factors that can give rise to such type of tumors?
Sir, the risk factors usually include smoking, sir, and occupational exposure to substances such as asbestos, silica, heavy metals.
Okay, that is called pneumoconiosis, asbestosis.
Sorry, sir.
Pneumoconiosis, asbestosis, like that.
Yes, yes, sir. Yes, sir.
Can you radiologically define whether it is primary or secondary?
Uh, yes, sir. Primary lung lesions are usually single in number. They'll be solitary lesion and they'll have spiculated margins, sir. And
Okay.
associated lymphedema could be present in few cases. And secondary lung cancer, secondaries are usually multiple, bilateral, and they are also well circumscribed, sir.
Good. So what treatment you will like to do for this person?
Sir, treatment if surgical based on the staging, we will decide the treatment, sir. If
Okay.
it is surgical resection is possible, we'll go for surgical resection and systemic therapy, sir. And if it is a stage 3 disease, we can go for definitive CTRT, sir.
Can you see the specimen
Ah,
display?
yes, sir. Yes, sir.
Please identify.
This is a gross specimen of breast showing mostly modified radical mastectomy specimen, sir.
I'm going to tell it is modified radical mastectomy.
Sir,
Why is
because it contains the entire breast tissue with axillary tissues also present, sir. That's why I'm saying it is modified radical mastectomy, sir.
So tell me what is preserved in a modified radical mastectomy and what is dissected?
Sir, in modified radical mastectomy, the structures resected are the entire breast tissue, nipple areolar complex, and axillary nodal levels are 1 and 2 usually, and pectoral fascia, sir. Pectoral muscle is preserved in MRM, sir.
So can you broadly classify breast cancer?
Sir, classification, sir.
Yeah.
Early,
Early breast cancer,
sir, early and locally advanced, sir, are the two broad classification, sir. Early
early,
and
or
locally advanced.
advanced, and metastatic. So how can you do the risk stratification for early breast cancer?
Sir, risk stratification depends on the tumor size, nodal status, ERPS status, HER2 status, Ka67 index, sir. If it is an early stage, we can,
Yeah. Yes.
sir, if it is an early stage, we can go for genomic studies, like genomic studies we can do, sir.
Oncotype DX, you have to do it.
Yes, sir, oncotype DX we can do, whether to go for adjuvant systemic therapy or post
What
surgery.
information does it give?
Sir, Oncotype DX, we'll get to know whether the patient is having a risk of recurrence, sir. So that's the scoring from 0 to 100. If the score is up to 25, the patient is considered low risk. And adjuvant systemic therapy can be omitted in those patients, sir.
Okay. Nice. So what are the biomarkers you like to test for this patient?
Sir, the biomarkers I'd like to test are ERPS status, HER2 status, and Ka67 index, sir.
AI 67. Okay.
Yes, sir.
So how does it help in treatment?
Sir, it helps us to know about the prognosis and also to guide the systemic therapy, sir.
Okay. Can you elaborate?
Sir,
Can you elaborate? Specifically, can tell, suppose ERPR positive, suppose
yes, sir.
positive, suppose triple negative, suppose Ki-67 is high or Ki-67 is low, what does it indicate?
Yes, sir. If the patient is ERPR positive and if it is a locally advanced breast cancer, we'll go for NACT first. That is adriamycin plus cyclophosphamide for 4 cycles. Uh, and we'll reassess the patient after NACT for surgery, sir. And ERPR positive, we'll also give 4 cycles of paclitaxel also, sir. If it is a TNBC, we'll go for adriamycin plus cyclophosphamide for 4 cycles plus 4 cycles of paclicarbo, followed by reassessment, and we can take up the patient for surgery, sir. Sir, this ERPR status will help us in deciding the systemic therapy, sir.
Also adjuvant therapy. And what about the HER2 positive?
Yes, sir. If the patient is HER2 positive, we can go for targeted anti-HER2 targeted therapy, sir. Like trastuzumab and pertuzumab.
Good. Can you tell the complications associated with this type of diseases when they undergo surgery and when they undergo radiation and chemotherapy?
Yes, sir.
These are the three modalities of treatment.
Yes, sir.
You subject the patient to chemotherapy, you subject the patient to surgery, you subject the patient to radiotherapy. So what complications you will encounter?
Yes, sir. In post-op settings, the acute complications could be seroma formation, uh, edema, sir. Long-term, the patient could have lymphedema, sir, post-surgery. And post-chemotherapy, the patient could have like peripheral neuropathy, sir, and also cardiotoxicities. And post-RT, acute complications will be radiation dermatitis, acute esophagitis, and RT also long-term complication. The patient could develop lymphedema, fibrosis, and radiation pneumonitis and cardiotoxicities.
Which is the most common you encounter in your clinic setting? Which complication?
So, the most common one, sir.
Yeah.
Sir,
Most,
dermatitis, sir, in acute setting.
okay. Long term.
Sorry,
What,
sir.
what more you find in your clinic setting?
Sir,
Okay, you will encounter lymphedema patients also.
yes, sir.
Patients swelling in the arm.
Yes, sir.
So how will manage such type of lymphedema?
Yes, sir. Lymphedema can be managed with compression garments, sir, physiotherapy, uh, skincare, and in a uh, few refractory cases, we can go for surgery also, sir.
Okay. So basically, you have to educate the patient post surgery as well as post radiotherapy, how to do exercise, how to do the masses, so that there should be chance of lymphedema will be reduced to the minimum.
Yes, sir.
Next slide. Is it visible? Next slide.
Yes, it's visible, sir.
Yeah. Please identify it.
Sir, this is a gross specimen of a long bone showing a lesion around the epiphysis and the metaphyseal region, sir.
It is a specimen that shows the gross disease at the one of the end of the long bone.
Yes, sir.
So what type of disease it is and from where it might have arisen?
Sir, from the gross image, it is
What is the most likely diagnosis?
Sir, it is most likely looking like arising from metaphysis, sir. So it could be osteosarcoma, sir.
Cross, you cannot see the metaphysis. Only theoretically you can tell that it might have arisen from the
Yes, sir.
metaphysis. So what type of disease it is? What
Sir,
is the
yes, sir.
what is the diagnosis?
Sir, it could be osteosarcoma, sir.
It could be osteosarcoma.
Yes, sir.
So this arises from the metaphysis. Can you tell any other tumor that arises from diaphysis also?
Diaphysis, Ewing's sarcoma, sir.
Okay. Tell me the radiological features you will find in osteosarcoma as well as Ewing sarcoma. First,
Uh,
tell osteosarcoma. What will be the radiological features so that you can tell the person might be having osteosarcoma without showing
yes,
the biopsy.
yes, sir. In osteosarcoma, the X-ray might show sunburst or sun-ray appearance and Codman's triangle, sir.
Good.
And in Ewing sarcoma, the X-ray could show onion peel appearance, sir.
Hmm. How osteosarcoma patients will present?
Yes, sir. The patients usually present with pain and swelling around the affected bone, and there could be a restriction of movement, sir. And they can also present with pathological fractures, sir.
Why there will be pain? Usually cancer patients do not have pain in early stages. Why this patient you are having present with pain?
Sir, if it is a periosteal involvement is there, patient could have pain, sir, because of periosteal involvement.
Okay, because of peripheral involvement, because of stretching of the tissues,
Yes,
skin.
yes, sir.
So there will be pain. So what investigations you like to do for this patient
Sir,
for a diagnosis?
yes, sir. First, I'd like to do X-ray of the affected bone, sir, and MRI of the affected limb, um, and the biopsy for confirmation of the diagnosis, sir.
Why MRI? Why not CT scan?
Sorry, sir. Sir, MRI to look for bone marrow infiltration. I'd like to do MRI, sir.
What are other things you look in MRI?
Sir, any neurovascular structure involvement?
Muscular bundle involvement you would like to see.
Yes,
Other
sir.
tissue involvement, whether it is resectable or unresectable, these things you have to see in MRI.
Yes, sir.
What is the most appropriate treatment for this type of patient?
Sir, the treatment would be like a neoadjuvant chemotherapy followed by limb salvage surgery, if possible, and then followed by adjuvant chemotherapy, sir.
Okay, come to the next slide. Can you see the specimen?
Yes, sir.
What is it?
Sir, this is a hysterectomy specimen showing a lesion arising in the uterine cavity, sir.
Okay.
So the lesion looks like it is arising from the uterine cavity. So it is mostly the most probable diagnosis is endometrial carcinoma, sir.
How these patients will present?
Clinical presentation, sir.
Yeah.
Yes, sir. Heavy menstrual bleeding, sir. Um, pain abdomen. Uh, abdominal distension, sir.
There will be abdominal discomfort. There will
Is
be menstrual problem. If the patient is premenopausal, there
is
may be intermenstrual bleeding. There may be heavy menstrual bleeding during the period. And if postmenopausal, there will be postmenopausal bleeding. Along with this, there will be lower abdominal discomfort, back pain.
yes, sir.
So, what are the risk factors for this type of tumor to develop?
Sir, for endometrial carcinoma, the risk factors are obesity, hypertension, diabetes, that is metabolic syndrome, smoking, and unopposed estrogen exposure, like early menarche, late menopause. These are the risk factors, sir.
Okay. So I will go for treatment of this patient.
Sir, treatment would be total hysterectomy with bilateral salpingo-oophorectomy and surgical staging, sir. Based on the post-op HPE, we'll decide the adjuvant treatment, sir.
What will be the adjuvant treatment?
Sir, adjuvant treatment based on the post-op HPE, and we should also do molecular profile, sir. And then we'll stratify the patient, and our adjuvant treatment will be based on the risk stratification, sir.
Can you tell?
Sir, risk stratification, sir.
Adjuvant treatment. Which risk group will go for what treatment?
You're asking about RT, sir?
Yeah.
Yes, sir.
What is the adjuvant you would like to do? What adjuvant treatment you would like to go for it?
Sir, adjuvant treatment, we have options like systemic therapy and radiotherapy, sir, or we can go
Treatment
for.
as well as radiotherapy.
Sorry, sir.
Yes, systemic therapy and radiotherapy.
The therapy we can go for vaginal brachytherapy also, sir.
Yes, yes. That also comes under radiotherapy only.
Yes, sir.
Come to the next specimen. Is it visible?
Yes, sir.
Please identify it.
Yes, sir. Sir, this is also a hysterectomy specimen showing a ulceroproliferative growth mostly arising from the cervix, sir. So the most probable diagnosis is CA cervix, sir.
It is from the lower uterine segment, so likely to be a case of
CA, sir. Yes, sir.
yes, cervix. So, what are the risk factors that is associated with the development of carcinoma cervix?
Yes, sir. The risk factors are usually persistent HPV infection and early ages at the first sexual activity, multiple sexual partners, immunosuppression, smoking. These are the risk factors for CA cervix, sir.
What are other contributing factors?
Um,
Low socioeconomic status,
Lower socioeconomic status.
smoking.
Yes, sir.
So
Poor personal hygiene.
can you give an idea of this epidemiology of this patients, epidemiology of cancer cervix in India?
Sir, it is mostly HPV associated, sir. Persistent HPV infection. It has a very long latency period, like 10 to 15 years, sir.
That is okay. When you are asked about epidemiology, you have
Yes.
to tell about three epidemiology agent. That is agent, host, and environment. So here, what is the agent?
HPV,
HPV
human
virus.
papillomavirus is the agent, sir.
Yeah. Host is
Patient, sir.
patient, and environment.
So unhygienic and socioeconomic status, sir. Like
Yes. Poor socio-economic status, unhygienic conditions, multiparity,
yes, sir.
multiple sexual partners. So which type of virus is mostly affected?
Sir,
What HPV? Can you tell some strain of the HPV?
yes, sir. Sir, we have low risk and high risk variants. Sir. Low risk are 6 and HPV 6 and 11. High risk variants are 16 and 18, sir. Usually, we have other variants also, but 16 and 18 are the most commonly associated with malignancy, sir.
Since it is the virus affected disease, so you can prevent it. Correct?
Yes, sir. Yes, sir.
So what factors can help you preventing this disease? How will prevent this disease?
Sir, we have vaccines available and we have screening options also, sir. So by effective vaccination and regular screening, we can prevent it, sir.
Yes, you can give the vaccine. You can screen the disease by
Is by pap smear and
pap smear. You can raise the socio-economic status of the patients or their surroundings. So these will help in preventing the disease in a large scale from the society. So how you do the pap smear? Can you give some idea?
is sir. Pap smear, ideally, we should start screening the patients from 21 years of age, sir. And we have it will be done using IS spatula and endocervical brush. We will take sample from around the transformation zone, sir.
What is that zone called?
Transformation zone, sir. Spermocolumnar junction.
Pharmacolumnar junction, right? Correct. Very good. Then
And pap smear should ideally be done every 3 years, sir. If we are also doing HPV DNA testing, it can be done every 5 years, sir.
which one is more specific? HPV DNA test or the pap smear?
Sorry, sir.
Which one will be the most specific?
HPV DNA testing is more
Sure.
specific.
Yeah. Pap smear is only the screening test.
Yes, sir.
So I will diagnose this patient.
Sir, for diagnosis, I'll go do biopsy for confirmation, sir.
Yes. And how will manage this patient?
Sir, based on the staging, sir, if the patient is from 1B3, we can go for definitive CTRT, sir.
See, management includes your investigation,
Yes, sir.
testing, then treatment.
Yes, sir.
So what investigations you would like to go?
Sir, I'll like to do CCT pelvis, sir, to look for any nodal involvement and CCT abdomen and pelvis, sir, to look for any nodal involvement or any other uh, to look for parameter
CCT abdomen
involvement.
pelvis you have done. You will know the nodal involvement. What more?
Sir,
How nodal involvement will help you in staging?
nodal involvement will upstage the disease, no, sir. 3C1 and 3C2.
Good. Then
Sir,
what more?
I'll also like to do a CT thorax, sir.
CT thorax for what?
Look for if there is any lung meds,
We'll
sir.
go for metastatic workup. So,
Yes.
okay. What more things you would like to do for this?
Sir,
Have you examined the patient? First, you have to go for a physical examination of the patient.
yes, a clinical
You have to
examination.
have clinical diagnosis first, figure staging.
Yes, sir.
Then you have to go for radiological investigations like MRI or CT scan, and then ultrasound abdomen, chest X-ray. So, like after doing this, you have to go for a, and also simultaneously you will go for biopsy that you have done earlier. So now you have confirmed that it is a case of CS cervix. You have staged it now. Now we will plan for your treatment.
Yes, sir.
And the stage.
Yes, sir.
Suppose it is low, you by physical examination you found it locally advanced. What more test you would like to do or investigations?
Sir, I'd like to do cystoscopy and proctoscopy, sir.
Yeah. How it will help?
Sir, it will, if there is a bladder involvement or rectal involvement, it will upstage the disease, no, sir.
To upstairs to
4A, sir.
4A. So what treatment you will like now?
Sir, we can go for, based on the staging, we'll decide the treatments. We can go for definitive CTRT, sir.
Basing on the staging. If it
Yes.
is advanced stage, from where to you like, from which stage you will like to go for CTRT?
Sir, from 1B3 and higher stages, we can go for a definitive CTRT followed by reassessment and brachytherapy, sir.
What should be the total dose in case of radiotherapy?
Sir, total EKDT should be 85 to 95 grays, sir.
Okay. So which technique you will like to prefer?
Sir, the technique.
For external RT as well as brachytherapy. For external RT, which technique you will like to prefer?
Sir, for external RT, IMRT with image guidance, sir. And post EBRT, we'll clinically assess the patient again and we will decide whether to go for ICRT or IBT, sir.
So technique you will prefer based on the availability. If you are in a good center setup, you will either prefer IMRT, IGRT, BMRT. Okay.
Yes, sir.
You can also treat by 2D if these facilities are not available. Then after external RT, what dose you will give to external RT?
External RT up to 45 to 50 grays, sir. If there is nodal involvement, we'll boost the nodes, sir.
So
55 to 58 grays, sir.
58 gram. Okay.
Yes.
What complications after treatment you will encounter during
Sir,
the follow-up of the patient?
sir, acute complications will be GA and GU toxicities like vomiting, diarrhea, uh, dermatitis, sir. And these are the acute complications, sir.
And late complications?
Late complications also, we can see cystitis, proctitis, vaginal stenosis, sir.
Okay, I will manage it. What complaint the patient will come and tell you?
Sir, in proctitis, a patient might complain of blood in stools, sir. And cystitis, patient might have a burning, maturation, hematuria.
So you will do investigation in that line. You have to do a proctoscopy. So find out whether it is actually due to radiation proctitis or something else. And in case of a bladder, you have to do cystoscopy to confirm that it is radiation cystitis. Then you have to plan the treatment accordingly.
Yes, sir.
Okay, come to the next specimen.
Yes, sir.
Please diagnose it.
Sir, this is a hysterectomy specimen with salpingo-oophorectomy, and it is showing mostly an ovarian mass, sir.
Okay. This is also a very common tumor in case of women in India. So which tumor marker you will be doing to diagnose it preoperatively?
Yes, sir. CA 125, sir.
CA120 will be raised in case of preoperatively so that you can suspect.
Suspect ovarian malignancy, sir.
Okay. What are the common routes of spread for such pathology?
Sir, most common route of spread will be transelomic spread, sir.
Yes.
And, uh, and also hematogenous spread, sir, but most common will be transelomic, sir.
Yes, one important thing you are forgetting. That is lymphatic spread.
Yes, sir.
I will treat such type of patients in case of CA ovary, I mean.
Sir, CA ovary, the staging is surgical staging, sir. So we'll go for a diagnostic laparotomy, and if it is operable, we can go for uh, hysterectomy with bilateral salpingo-oophorectomy, sir, and we'll surgically stage the patient, and treatment will be based on decided based on that, sir.
Good. Any role of radiotherapy?
Sir, if there are peritoneal mets, we can go for whole abdomen RT, sir.
Not exactly. So there is no upfront role of radiotherapy except in metastatic setting.
Okay, sir.
Come to the next specimen.
Yes, sir.
What is it?
Sir, this you can see a ulceroproliferative lesion over the sole, sir. From the gross appearance, it is most likely looking like a squamous cell carcinoma, sir.
From gross appearance, you are thinking that is squamous cell carcinoma. No. It looks like malignant because of irregular shape, cavity,
Yes, sir.
necrosis. Then you will do the biopsy, then you can know that it is a squamous cell carcinoma. Anyway,
Yes.
so what is the most common histology?
The most common histology is squamous, sir.
Okay. So your provisional diagnosis should be?
Sir, provisional diagnosis squamous cell carcinoma, sir.
So what are the differential diagnosis?
Sir, it could be basal cell carcinoma or melanoma, sir, or Marjolin's ulcer, sir.
Marjolin ulcer, basal cell carcinoma, varicose carcinoma. It can be
Yes,
fungal infection also.
yes, sir.
So what investigations will do for this patient?
Sir, yes, sir. I'd like to do biopsy for confirmation, sir, and MRI of the affected. For
What type of
MRI.
biopsy will do?
Sorry, sir.
What type of biopsy will do?
Punch biopsy,
Yes, sponge biopsy.
sir.
Next, investigation.
Investigations. I would like to do MRI of the foot, sir, and if there is a node to look for nodal involvement, I'll do ultrasound and FNAC, sir.
FNS about
If any node is suspicious, I'll do ultrasound guided
FNS of the node. Okay. Supposing that it is node negative, it is a localized disease. What treatment you will like?
Sir, if it is a localized disease, we can go for wide local excision, sir. Or we can go for brachytherapy also, sir.
Oh, for such type of disease, brachytherapy is not suitable.
Okay, yes, sir. If it is localized, I'm saying, sir.
So you have to go for excision.
Yes, sir.
Depending on the size of the tumor. Sometimes you may have to sacrifice the limb also.
Yes, sir.
That part. So what are the potential complications?
Complications, sir.
Yeah.
Patient will have a functional impairment, so if we go for amputation, and post-op patient could develop infections, sir. Uh,
Continue.
yes, sir. Sir, functional impairment, post-op infections. Only.
Suppose you have not excised the tumor. It is there.
Yes, sir.
How it can progress?
It can locally destruct the underlying structures like muscles and bones, no, sir. And it can metastasize to other sites also, sir. Distant mets.
To where? Most
Sir,
common site for discernment.
uh, skin, I'm not sure, sir. Lungs,
Lungs and liver.
yes, sir.
What more?
Uh,
Eating, it can lead to ulceration, functional impairment.
yes, sir.
So you have to manage accordingly if it is as per the staging of the disease.
Yes, sir.
See the next specimen.
Yes, sir.
What is it?
Sir, this is looking like a testicular specimen, sir.
Cartomum.
Sir, from the gross appearance, mostly it is looking like seminoma, sir. Because it is looking homogeneous, sir.
Okay. Maybe seminoma. So what investigations or marker studies you would like to do for these vessels?
Yes, sir. Investigations I'd like to do tumor markers, sir, and scrotal ultrasound, sir. CT abdomen and pelvis, uh, chest X-ray or CT thorax, sir.
Okay, what tumor markers you will go for it?
So tumor markers that we usually check are alpha fetoprotein, beta HCG, LDH, sir.
What information they will give?
Sir, if alpha fetoprotein is elevated, it is elevated in yolk sac tumors and embryonal carcinomas, sir. Beta HCG will be elevated in seminomas and also choriocarcinomas, sir. And from LDH, we can get to know about the tumor burden, sir.
Okay. So tumor markers help classify the disease and stage and guide treatment and prognosis. So which type of seminoma can metastasize into brain?
Uh, Sir, choriocarcinoma, sir.
Good. Come to the next. Is it visible?
Yes, it's visible, sir.
Yeah. Please describe.
Sir, this is an enucleated eyeball showing a lesion arising in the posterior aspect, mostly from the retina. So the most probable diagnosis is retinoblastoma, sir.
Okay, supposing that it is retinoblastoma, what will be the presenting features?
Yes, sir.
Simply.
Yes, sir. Clinical presentation mostly it will be leukocoria, sir. That is white pupillary reflex, and the patient could also have strabismus, diminished vision, proptosis, sir.
What investigations, imaging investigations you would like to go for this person?
Sir, B scan, sir, B scan and MRI of the orbit, sir, to look for extraorbital extension if it is there or not. Sir, uh, the slides are not visible, sir.
Am I audible now?
Yes, sir. Yes, sir. It's audible, sir.
Screen is visual, huh?
Yes, sir. Screen is also visible, sir.
So we are talking about retinoblastoma. Please come to the question.
Yes, sir.
So, which genetic mutation is associated with such type of pathology?
Sir, usually RB1 mutation is associated, sir.
Now, I asked you one question, that is, why not a CT scan for this patient?
Sir, we have to look for optic nerve involvement also, no, sir. That's why we'll advise MRI, sir.
There is another more important cause. What is the age group of the first type of pathology?
Sir, usually pediatric age group, sir, less than 5 years
So
of age.
we don't like to expose the patients to radiation.
Yes, sir.
So we will avoid such type of investigations.
Yes, sir.
So the two key imaging modalities is B scan and ultrasonography of the eye.
Yes, sir.
Can you tell the indications of radiotherapy for this type of patient?
Sir, yes, sir. Usually, we will first stage the patient, and if the patient comes under group C, we can go for brachytherapy. So that is plate brachytherapy, and sir, sorry, sir.
What is that group C? When you will call it group C patient?
Group C, based on sir, group C, it will be a tumor with subretinal seeding, sir.
Group C is localized tumor with focal seeding.
Yes, sir.
So what you will do here?
Sir,
Brachytherapy,
yes, sir.
usually plug brachytherapy.
Yes, sir.
Then for group D disease, what is it? Diffuse vitreous and subretinal seeding. So if there is some incomplete response from chemotherapy or focal therapies, we can go for radiotherapy. Salvage treatment also for persistent disease and for refractory tumors.
Yes, sir.
So we can also consider this external RT also.
Yes, sir. External anti, if like post enucleation, if there are high risk features, we can go for external anti, sir.
For localized disease, it is plaque brachytherapy, and
Yes,
for post enucleation, we can go for external radiation. And for other patients, if the
sir.
disease is extensive disease, no visual potential is there, and there is a high risk of metastasis, post enucleation EBRT, if histology pathology shows optic nerve or pattern involvement is there, massive choroidal invasion is there, extrascleral extension is there, so we can go for EBRT for such type of patients.
Yes, sir.
Come to the next patient. What is it? Is it visual?
Yes, it's visible, sir. Yes, sir. This is a gross specimen of ovary, sir, showing materials like hair, tooth or bone, and also sebaceous material, sir. So it is mostly cystic, mature cystic teratoma, sir.
Why you are calling it is mature?
Uh, sir,
When you can identify tissues originated from the three germ layers,
yes, sir. Yes, sir.
ectoderm, mesoderm, endoderm,
Yes,
then
sir.
you can call it a mature teratoma.
Yes, sir.
From which cell this type of tumor arises?
Sir, these cells arise from totipotent germ cells, sir, because they will differentiate into these all three germ layers, sir.
Nice. How the patient will present?
Patients usually present with pain abdomen, abdominal mass, um, sir, menstrual irregularities.
Yes.
Sometimes acute presentation could be torsion also, so ovarian torsion.
And sometimes incidental also.
Yes, sir.
How often it is transferred to malignancy?
Sir, mature teratomas, the malignant transformation is very low, sir, less than 2%, sir.
Less than 2%. Good. How will manage it?
Sir, if it, we should see if the patient is premenopausal or postmenopausal, sir. Premenopausal, we can go for ovarian cystic, we can go for fertility preservation options, sir. Postmenopausal women, we can go for oophorectomy, sir.
Okay. Next specimen is visual.
Yes, sir, it's visible, sir.
Please identify it.
Sir, this is a surgical specimen showing gastrectomy specimen, sir, with lesion, ulcerative lesion along the lesser curvature, sir.
Okay. First, you have to tell how you diagnose that it is a stomach.
Sir, because we can see the uh, rugosities, no, sir. That's why I told stomach, sir.
Again, pyloric gland, lesser curvature, greater
Yes,
curvature.
yes, sir.
Name the most common histological types of such type of pathology.
Sir, adenocarcinoma is the most common type, sir.
Only adenocarcinoma. And in G junction, we can have adenocarcinoma as well as squamous carcinoma.
Yes, sir.
What are the risk factors for such type of pathology?
Sir, the risk factors are usually chronic gastritis, H. pylori infection, sir, smoking, and nitrosamines in the diet, family history.
I will get nitrosamine in diet.
Sir, nitrosamines are usually
If you take smoked food,
smoked food, sir, yes, sir.
so where it is most prevalent in India?
Sir, nitrosamines associated, sir.
Obviously,
Northeast, sir.
northeastern region.
Yes, sir.
The region where the people take smoked food,
Yes, sir.
burnt or incomplete burnt meat, there you will get this type of tumor.
Yes, sir.
Other risk factors include this Helicobacter pylori. So
Yes.
Helicobacter pylori is one of the cause of gastritis. How often it is getting transferred into the malignancy?
Sir, here also the risk is very minimal, sir. I'm not sure about the numbers, but like 2 to 3%, sir.
1 to 2% or 2 to 3%. ठीक.
Yes,
Other
sir.
risk factors are smoking,
Yes,
alcohol,
yes, sir.
and also family history.
Yes, sir.
Name one paraneoplastic syndrome associated with such type of pathology.
Gastric carcinoma, they could have acanthosis nigricans, sir.
Yes,
Where,
yes.
yes, sir.
Process syndrome. That is migratory thrombophlebitis.
Yes, sir.
So next specimen is visual to you.
Yes, sir.
Please identify the specimen.
Sir, this is a gross specimen of like nephrectomy specimen showing a lesion in the cortex with areas of necrosis and hemorrhage. So, mostly it is renal cell carcinoma, sir.
Nice. So renal cell carcinoma is the most common histological type associated with such type of pathology. What are the common paraneoplastic syndrome associated with this type of pathology?
Sir, in RCC, erythrocytosis because of increased erythropoietin production and hypercalcemia, and these are the paraneoplastic syndromes usually associated, sir.
Erythropoiesis,
Is erythrocytosis and hypercalcemia, sir.
hypertension.
Hypertension, sir.
What imaging modalities you will prefer for evaluating?
Sir, CCT abdomen, sir.
CCT abdomen.
Yes, sir.
How will treat?
Treatment, if it is a localized disease, we can go for partial nephrectomy, and if it is a large tumor, we can go for a radical nephrectomy, sir. Followed by systemic therapy, sir.
Any role of radiotherapy?
Uh, Sir, radiotherapy usually in a palliative setting, sir.
Palliative.
Yes, sir.
What are other treatment options available?
Sir, we have targeted therapies like, sir, like immunotherapy, sir.
Yeah. Now look at another specimen.
Yes, sir.
Tell me something about it.
Yes, sir. This is a gross specimen of a long bone, mostly femur, looking like femur, sir, and you can see a lesion arising in the medullary cavity, sir, and it is also eroding the cortex of the bone, sir.
So what is the most likely diagnosis?
Sir, it is looking arising from the diaphysis, so it could be Ewing sarcoma, sir.
What are the radiological features?
Sir, in Ewing sarcoma, the X-ray will show usually onion peel appearance, sir.
Which age group is commonly involved for such type of disease?
Sir, Ewing sarcoma is most common in adolescent age groups, sir, like 10 to 20 years, sir.
So what is the most common cause?
Sir, translocation, sir, translocation of 1122, sir.
Okay. I will treat.
Sir, treatment, sir, a neoadjuvant chemotherapy followed by limb salvage surgery if possible, or if surgery is not possible, we can go for definitive RT, sir, followed by systemic therapy, sir.
Okay, surgery and or radiotherapy and adjuvant chemotherapy.
Yes, sir.
Nice. So we have come to the end of the session. Dr. Kanucharan Patra, okay, is not available. So I thank you all for attending the session. I thank you all the faculties who are present. So I would like to end the session. Anybody like to comment anything? So thank you all. I am closing the session. Please come again tomorrow 7 o'clock for another session.